We are live now, sir.
I hope you can see my screen well. Hello, good evening. Welcome to the second Enabling Technology ASSI Study Group webinar on robotics versus navigation. Is there incremental value in pedicle screw fixation and beyond? Friends, we met last week and had a very interesting webinar, but we intend to carry further the discussions today on a very important topic where we try to compare robotics with navigation in our day-to-day surgical practice. The scope of today's discussion, what are we comparing? Robotic and navigation assisted versus computer assisted navigation, which would be standalone. What we are not comparing, robotics or navigation versus freehand. This is a well established superiority. The focus area would be any incremental advantages in accuracy, workflow, safety, and cost effectiveness. And this is totally vendor agnostic. The evidence from multiple platforms would be presented, and we are not going to compare any of them. Why this discussion matters? Both technologies improve pedicle screw accuracy. Incremental benefit is increasingly questioned. Decision making must be evidence driven because we are all in an era where evidence and experience matters when it comes to patient management. What do we mean by incremental value? Additional benefit beyond standard navigation. A clinical relevance, not just statistical significance, and of course across multiple domains. And when we compare, we examine accuracy improvements, error pattern differences, learning curve dynamics, operative time, radiation exposure, OR efficiency, and ultimately the value proposition, cost effectiveness, clinical outcomes, and sustainability. What incremental value is not? It's not a marketing superiority, it's not replacement of surgical judgment, and it's not universal. And we'll look into, are there any key takeaways? Is value equal to technology? Is there any clear winner between the two technologies? And will AI integration and dynamic registration reshape the conversation? Friends, we will discuss this and much more over the next 90 minutes or so. And we have a scientific agenda with which we'll move. But I will hand over the moderation now to the chairpersons, Dr. Soumyajit Basu and Dr. Shankaracharya. Over to you, Soumyajit, for taking this further.
Thank you, Dr. Chabra. It's my distinct honor to welcome all the faculties into this webinar. We have a wide array of faculty today representing the most happening parts of the country. We have initially a very interesting debate coming on whether navigation and robotics have an edge over each other so far as pedicle screw fixation is concerned, regarding the accuracy and the long-term sustainability, and also I'm sure about surgeons' experience and certain safety. So I'm sure all of you who are watching this will be benefited with this webinar, and I have Dr. Rupinder Chahal as a co-moderator. Shankaracharya is unfortunately traveling, so I will be moderating till 8:30 and leave the rest for Chahal. So before time flies away and takes a portion of your interest, I would invite Dr. Bhavuk Garg to start the debate. He will be debating with Dr. Sailesh Hargaonkar. Bhavuk actually needs no introduction. He is heading the spine unit at All India Institute of Medical Sciences in New Delhi, one of the premier institutes in the country, doing most of deformity surgeries. And Shailesh is the head of the spine unit at Sanchetin Institute in Pune, where he also heads a very premier institute in spine surgery with a huge volume, and his main focus is MIS and endoscopy. So over to you two guys for beating up each other. You have 7 minutes time initially, and then a rebuttal time after that for a few minutes before we wrap up. Put to you, Babu.
Thank you, sir. So I'm sharing my talk. So the task given is to me is that I have to proposition that the robotics, they provide any incremental value in particular screw fixation over the navigation. So one thing I would like to emphasize, especially to our juniors, that navigation is the core of robotics. So you can't separate the navigation from the robotics. And in fact, if we talk about the future and the current status, the hybrid technique, the use of navigation with robotics is the best overall. So having said that, we know that the innovations, they are basically of two types, the disruptive and the incremental types. So the disruptive is which completely changes the scenario, like endoscopy, it completely changed the spine practice in that area. The incremental is something which increases the value of this thing. So having said that, I'm fortunate that I have the experience of using both the navigation, the robotics. So I will be presenting an unbiased and the personal view that why I think that robotics is better than navigation. So as I already told you that the robotics is an incremental innovation. So this brings us to the question that why actually we ever thought of robotics, because there was something amiss in navigation that prompted us to go for the robotics. And this is a very famous the Simon Sinek's talk, and his TED talk and his book, that always start with why. And this why is very important because we want to increase the safety of the spine surgery whatever we are doing. So incremental innovation in spine surgery doesn't change what we operate on. It basically changes that how safely and reproducibly, we can do it. And spine surgery has not evolved by revolution. It has evolved by systematically removing the human error. So this human error still remains the weakest link when we are using the navigation. Now, if we talk about the basic difference between navigation and robotics, it is about seeing versus doing, or you can say it is about guidance versus controlling your trajectory or your surgery. So navigation is basically, it is showing us the path, but we have to rely upon our driving skills, whether we are able to drive on that given path or not. So this human hand becomes very, very important because we know that as humans, we are prone to fatigue, we are prone to drift, we are prone for tremors, especially if you're a high volume surgeon, if you are doing high complex surgeries, one after the another, then these factors, they come into play definitely. And robotics is meant to decrease that error in your practice. So what does robot do? It locks your navigation. It locks the trajectory. It maintains the integrity of your navigation. So there are no tremors. So there are no excuses. So we all know that navigation can still make error. It can make multiple errors. Robot can also make an error, but it stops it from committing that error. So that is the important difference, and that is the important incremental value of the robot or the navigation. So if you look at just the how we have progressed in this the direction is that we evolved from freehand, where we mastered the anatomy. We tolerated the wide variability in the particular screws. We accepted the in-out in screws also, and the outcome depended upon the who is operating. And excellent surgeons, they produce excellent results. However, they were inconsistent in their results. So then came this fluoroscopy or the navigation based era. We reduced the ignorance in this era, but we did not reduce the execution drift. And surgeons still remain the weakest link. However, they were the strongest asset still in this era. And we learned to see better, not to control it better. Then comes the robotic, the present era, and now the planning plus visualization has already solved the problems in the previous era, but the remaining problem, the manual deviation, still remains the problem. And robotic actually adds that physical enforcement of that intent. So for example, there is something called the dual mobility cup in hip replacement. It is same like to reduce the chances of dislocation. But what is the most common complication of dual mobility cup? It is still the dislocation. So if it is still this manual error remains the major factor if you are not well versed with your robot, then again you are prone to error. But however, it is still provides an incremental value over the navigation. So robotics doesn't question your judgment; it stabilizes your execution. So robotics shows its true value after a surgeon who understands the pedicle morphology intuitively, who can recognize the high risk anatomy instantly, and who knows when not to trust this automation. So robotic amplifies your expertise; it doesn't replace it. It is safest in those hands who actually don't need it. So the statement that robots are more accurate than surgeons, it is completely wrong. It's basically robots are more consistent than surgeons on their worst day. So this is very, very important thing to understand. So the scenarios, where the robotics fits this incremental logic, especially these conditions like the thoracic pedicles, the margin of error is small. The chance of complications are very high. Severe scoliosis, where the landmarks are distorted. Revision surgeries, when there are loss of tactile cues. Dysplastic pedicles, where the anatomy defeats the experience. And the MIS, minimally invasive surgeries, where you have the vision without tactile feedback. In those scenarios, the robotics definitely provides an incremental value over the traditional navigation. So the surgical evaluation in spine has never been about doing the new operation. It is about making the same operation safer in the worse anatomy. And just to summarize this thing, the freehand, it perfected your judgment, navigation perfected the vision, but robotics, it perfects the execution. So navigation solves where, robotics solves the how. Navigation improves the visualization, it leaves the execution fully manual, which is prone to error. Robotics physically enforces the chosen trajectory. So this is very, very important. It locks your navigation. So seeing the error is not same as preventing it. So high volume surgeons, expert surgeons who are performing more complex cases, who are operating longer hours, who are taking on higher risk anatomy, they are the perfect candidates where the robots provide the incremental value of the traditional navigation. So robotics benefits surgeons who are already operate at the edge of tolerance. If you're a low volume surgeon, your main practice is open surgery, then probably robot is not for you. Robotics, they've consistently showed the evidence-based reduced variability, improved accuracy in difficult anatomy, better reproducibility across the surgeons, and it is optimal for the minimally invasive fusions in osteoporotic spine. It is still emerging for deformity or the cervical spine. It is not suitable for open surgeries, especially in obese patients where this large soft tissue, the walls, it again doesn't lock the trajectory of the robot, and it's not suitable for very small children, where the instruments are quite large for these pediatric age group. So science advances by reducing the outliers and not celebrating the averages. And robotics is not for the surgeons who lack skill. It is for the surgeons who refuse to let variability harm their patients. So to summarize, the navigation informs, but the robotic performs. Thank you.
Thanks, Babuk. That was really brilliant. Thanks for keeping in time. Sailesh, you're after Babuk now. You have to
Yeah.
prove that navigation is much better. You have to prove that Pune wins all its cricket matches from Delhi. Over to you.
Hi. I think Bhauk is really summarized it in a very beautiful fashion, and I think it's not a debate; it's the technology which is coming up, and we will share our experience with the navigation and why we have started doing this. And this is just quickly. I'll go through my cases, and this is a 65-year grade 2 listhesis, overweight patient. You have everything, but you can just, you have your expertise of MIS and open surgery, but this is really helping you. You should know how to use everything under the table, and you are just using it in a very, very simpler fashion. Interbody clearance is important, placement of cage is important, and once you know this, it becomes very easy. And now we are sitting with around 15,000 navigation-based surgery screws. We are really happy. Therefore, we were about to buy the robot. We thought, no, no, we are really comfortable because we can do cervical, dorsal, deformities, anacondas, and all these lumbopelvic fixations. And this is what we have realized that this navigation is currently the gold standard. It is got the answer to most of the difficult problems today. We have done grade 3, grade 4 lists. This is with with the navigation endoscopically. We have published our series, and the navigation is going to be the future. For it's not going to be the future, it is future. Robot will be coming up with more maturity. It is going to take time. I'm not saying that we will have issues, but various things which when we analyze, we realize that navigation really can be a great answer. I am not going into the debate of what's better, what's real time, but it's our own experience, our own public. We have published around 12 papers on navigation, five papers on endoscopy based navigation, and we have published our percentage of accuracy with navigation around 99% in osteoporotic spine. I was just thinking that robot is a good pedicle finder and pedicle screw fixator. It's not anything else. It has no other knowledge. It will come there, it will just put. If it is a osteoporotic spine, doesn't make a difference. Robot will put the screw and go away. It doesn't understand the pull-out state, nothing. It has got a job to just, it's a pedicle finder. That's it. But navigation will tell, because you're using a brain tactile feedback along with the navigation. It's the ultimate thing. You know what you're doing, and there is no need for searching for alternative option when you have best option today, because this is just a tool. It's like a gimmick right now. The marketing companies, this hospital has a robot, that hospital has a robot. Actually, it is not of great help. And we are analyzing the data. We are coming up with a lot of data. There is no tactile feedback because the robot is putting the screw. It's just a pedicle finder. It's putting the screw anywhere. That's it. You just guidelined pedicle screw finder. Is it of a great help? I will not name, but big people in India, one of the greatest guy in India was talking. I have both the things, but I don't feel the robot. He says no, navigation is the best right now. People who have robot, they say, oh, array, wo to, it's there in the operation theater, but we use navigation. Because why people are talking? Because there is a rationale. User friendly. It's not going to make a surgeon better, but a bad surgeon better, but it will make a good surgeon really good. It will, and there are so many papers. If I keep going into the comparisons, it will, it's not a right thing to just keep comparing robotic versus navigation. But where is the brain? Brain is application. You are saying that you classify and you plan. You don't need to do that. You are planning it, and you have everything in front of you. You really can derotate the deformity with a beautiful apical screw in a deformity. That's the benefit of a navigation. It's not just putting the screw. We have so many cases like this in deformities, and people have refused to touch these patients. It is a great thing. A lot of skiving is there in robotic. You cannot put a good screw in such. I am not saying for all, but experts can really do it. But for not for general people, you need to understand this. If the navigation comes, this surgery will become less risky to most of the Indian people, because your accuracy rate is significant even in this kind of deformation. This plastic pedicles, you really can go and you have a tactile feedback. No visceral, no vascular injury. You really can do this when you put a screw in a good deformed vertebra. You really can have a good deformity correction in such bad deformities as well. And various cases we have done a lot of syndromic various cases, and every means we have found so much of. This patient comes from Nagaland. We have so much improved outcomes with navigation, and that is the big advantage. Osteoporotic spine, I think it's the biggest help. Revision spine surgery, again, navigation scores very, very high, because you know what you're doing, how you're putting the screws, how much it is identifying, it is telling how much is the extent of the surgery, where is the problem, where is the failure, and how much decompression you have done, because it is checking it on table. Such cases where you have problems, you really can have one of the best answers. This is a sat nav technology technique which we are doing, and we have sent our paper for publication third time, fourth time. 150 kg patient, 180 kg patients, doesn't make a difference. This surgery is ultimate because you know where you are doing. This is 1.5 year follow-up. Patients are coming and they're doing everything, and we published multiple different cases with navigation, sacroiliac fixations, and deformity, tumor. You can actually see how much the extent of tumor you've done, where you want to resect, how much you want to resect. And that's the beauty of a navigation. I think today navigation is a gold standard. Next 10 years, it's going to be the gold standard. Let the robot mature, let it come with a lot of advancements, and I think we are ready to accept any technology which is going to be useful. We are not saying that robot is not good. It has a very small, minuscule amount of advantage in some part, but 95% I think navigation is going to be a great asset for everyone. This is a distal junctional failure. We really can plan it so well, we can fix it, and really we can get out with difficult, challenging scenarios. You just don't need to think. Next day you go to the theater, you plan it, you put your navigation is out, no radiation. You are not wasting time at all in the theater. You are just doing things which you want to do. Pediatric spine, C1, C2, you name it, you can actually get things sorted with this. And it will be too much to say, but these are our publications which we have, and we are really happy. I think it is going to be the next era will come, safety will come for next 10 years. If the price of navigation comes down, I think India will show great outcomes worldwide, and I think robot will take over maybe subsequently. But right now, I think we should continue using what we are doing. Thank you once again for patient hearing.
Thanks, Bhabuk. Can you just share your screen? That's great. So, Bhabuk, I'll give you 1 minute, and then Sailesh 1 minute before we go ahead with the next talk. And Bhabuk, all yours for the next 1 minute.
So I think this Alish has already answered my rebuttal, that he already said that the tactile feedback is very important. So especially those conditions where tactile feedback is not there, the robot definitely provides an incremental value. So like flexible spine, which is too much flexible, where your navigation is just by going to change with your, even try to do the tactile feedback. Osteoporotic spine, when there are chances of the spinous process breakage, where you put your, the baseline array, and especially in the MIS cases, and the complex anatomy cases, those cases, where you need the robot. In most of my cases, yes, we can get away with the navigation, but revision cases, all those cases where tactile feedback is an issue, there the robot is the answer. Having said that, robot is a combination of navigation plus robotics. So if you use them as a hybrid, this thing, so that is the best tool, you can use it. However, again, I admit, as I told in my talk, that there are certain limitations right now. And yes, we are evolving. Robot is just the first incremental innovation in the navigation. In coming future, it is going to involve all the soft tissue dissection, going to do the osteotomy on this thing. It is going to come. It is going to be part of the future. We can't deny it. The driverless cars, they are going to the future. We can't deny it. So we are evolving in that direction. So definitely.
Thanks, Sailesh. A minute of your rebuttal.
I think, thank you, Bhauk. It's a catch me if you can. Bhauk is a very dear friend, but today he's really trapped himself in a very bad situation, and he's telling me about tactile feedback. In osteoporotic spine, this pedicle finder is just putting pedicle screw. It doesn't know how the hold is, but when you're using navigation, Bhauk, just remember you can have a bicortical, tricortical hold, and your pedicle screw pullback is absolutely better. This pedicle finder will put you into trouble if you just believe it that it is going to put. It is not going to replace your thinking, because it's got no hole. It's just putting screws and coming out. Patient is having problem. After 15 days, the screws are backing out. That's the problem with the robot. But it's a marketing gimmick. People just want to show, yeah, we have a robot, we are doing it. Understand, in you, even if you don't use the pedicle finder, you just do it without the pedicle finder normal, you will do a better surgery than a robot. So better avoid the risky robot, do a standard surgery, or navigation is the ultimate. That's what I feel. Thanks.
Thanks, Bhavuk and Shailesh, for an interesting debate. And before Bharat Dave is itching to bring in his Airavat into the webinar, I would just tell him that I'm sure Mirand is going to take over with a beautiful talk in the next 20 minutes. And before that, I think both of you have not considered the incremental value of navigation or robotics over the other in terms of the healthcare costs involved. I think that was a point which both of you could have brought up, because the debate is never um, completed unless we really look at the cost. Because at the end of the day, the patients are going to pay the cost.
Yeah.
Whereas navigation versus robotics, if you really look at the incremental monetary value which robotics actually brings it into the system, whether the incremental value is worth the cost or not, worth the extra burden of cost to the patient or not, that also needs to be really decided upon. We have a couple of speakers down the line. Mirand is doing an excellent job. He is now the heading the Department of Spine, so far as robotic spine is concerned, in Stavia Hospital. As you all know, Stavia is one of the most prolific hospitals in Gujarat, which has been delivering healthcare in spine for now 20 years. And to follow Miran would be Luca, and I would invite Dr. Chabra to introduce our guest speaker after Miran finishes off. Over to you, Miran.
Thank you for the kind introduction, sir. So I'll just put this first slide for clarifying that we have put only 1200 plus screws with the Mazor, but 20,000 plus screws with the navigation. So we at Stavia call it Stavia's Integrated Operation Theatre Spine Suite. We just had our fourth OAM installation, and we have 3 navigations, 1 robot, exoscope, and bone scalpels. So the topic given to me today is beyond pedicle screws. Does robotics add value elsewhere in spine surgery? Now, what I believe is navigation has already optimized accuracy. Robotics must justify the incremental value. Value is equal to outcomes, efficiency, safety, and scalability. So the key domains where robotics may add value is deformity, revision spine surgery, tumors, MIS workflows, complex anatomy, and consistency. So robotics in deformity surgery, well, preoperative planning for long constructs is easier with the robot. Precision in altered anatomy is better with robotics. Reduced fatigue and improved consistency. Of course, still limited high level outcome data is lacking with the robot. But I'll show a few of our cases. So this is one of the examples where, of course, this is a dorsal pedicle. It's easier to handle a dorsal pedicle with robotics because it is more precise, more accurate. You can plan better. Again, an S to AI screw or an iliac screw. So the beauty of robotics for me is the 70,000 RPM drill. This drill goes straight on the trajectory which has been planned. And then we can use this tip-tap all and go right into the trajectory. Again, robotics in revision spine surgery, where we have distorted anatomy, prior implants, we get safer trajectories. We have even put 2 pedicle screws in a single pedicle level with the help of robot. Of course, there is reduced guesswork and strong face validity, but there is limited comparative evidence here. So we have attempted cervical spine. Again, we were happy with the outcomes, but then this is something which is into the future. Now, robotics in spinal tumor surgery is where stabilizing is in the compromised bone. Again, it helps with the oncology tumor planning, and the accuracy, of course, matters on the biology. But then this is one of the constructs that we made. This is a spine tumor patient. We did a 4-rod construct. Now doing this 4-rod construct is much easier with the robotics because we can plan each pedicle and the rods as well. So here, as you can see, we could very easily do a 4-rod construct in the lumbar. Again, the same here, a tumor case where you can see an absent pedicle on the right side. But then planning with the robot helps with the planning and execution part in such cases. Of course, majority of the cases that I have done is MIS, and the workflow standardization is best with robotics. It reduces radiation exposure. The team learning curve improvement is gradual, but then the potential OR efficiency gains are many with robotics. Again, this is an example of a case where we can use docking procedures, and we can plan the trajectory on the robot and then dock accordingly wherever we wish to dock. So it can also be used in revision spine surgeries for docking. Now I'll just show an MIS workflow where how robotic surgery is done at Stavia. So of course, it is a table mounted robot. It goes and mounts to the table. Then the table, patient and robot become one unit. And then what we usually do is the MIS screw insertion is where we do it later. The first thing we do is we put in the cage. So with robotics, putting in the cage first without any guidance is what we do. Currently, we use the robot only for pedicle screw planning and nothing more. So after the docking is done, we are in with the cage. We go for the routine 3D scan, snapshots, and then the planning on the robot. So as you can see, this is an osteoporotic wedge fracture, and we are planning on the robot. So this planning is very efficient with the robot. You can see there are narrow pedicles. The trajectory planning is very accurate. We can see each and every pedicle. We can plan the rods. Even here, we can get the inferior directed trajectories. And then we go the routine way. So now MIS fixations with robotics is where the drill is very helpful. Of course, a challenge in India is using the Indian implants with the MIS workflows, but then we have been able to use it very efficiently. So the current evidence, I feel the gaps are accuracy data is strong, but the clinical outcome data is weak, linking it to the robot. Cost effectiveness is still unclear. We need a procedure specific evidence for robotics for it to get implemented more. Of course, there are a lot of future directions, AI assisted planning, which would make the planning part very easy. Self-planned screws would make workflows very, very easy. Learning algorithms, of course, are being used. Outcomes linked robotics is where the research studies should be aimed. From hardware accuracy to surgical intelligence, this is where robotics should be heading. So the take home message from me is robotics add value beyond screws, but selectively. Strongest role in complex repeatable workflows. Evidence must move from accuracy to outcomes. Adoption should be indication driven and not technology driven. Thank you for a patient hearing.
Thanks, Mirand. We have a little bit time for some discussions. I'll start off with a small question or something which all the faculty would be encouraged to answer. So, in a routine standard patients, when we are putting in freehand pedicle screws, I think even in experienced hands, there would be approximately an 8 to 10% deviation from the absolutely correct, but there might be a grade 1 or a grade 2 pedicle screw each, which comes down to less than 2% using navigation or robotics. So from 8%, you have come down to 2%. Now, how much of these pedicle breaches are clinically a problem? And if that clinical problem is less than, say, 10% of the breaches, then from 8% you have 0.8% of clinical problem, and from 2% you have 0.2%. So this 0.2 and 0.8%, are they really, really statistically significant, and does it help in pushing forward the incremental cost? So I'd start off with Bharat possibly, and then Sailesh, and then Bhavu, and then possibly Iraq.
Yeah. I think it is significant. And this significance has to be considered. And if we consider a simple MISS case whom we end up giving the foot weakness, then it certainly matters the most. So certainly we should go for 0-0 outcome, meaning 100% outcome and 0-0 complications. So that is where, the technology integration would be of great help.
So I just give an example. If a patient comes to me and asks about the complication rate in particular surgery, and I tells him that there is 0.1% of that thing, but we don't know that who's going to be that 0.1%. Similarly, if we are talking about that there is an error, which we can reduce from 8% to 1%, I will prefer to reduce the error, whatever, because we don't know the consequences of that, the 6% which we are reducing, that what could be the consequences of that thing. However, if you look at the overall data cost effectiveness, then probably this may not matter. But obviously, as a surgeon, I would prefer to reduce my complications, especially if it is a high volume center, then these things do matter.
Yes.
Yeah, sir, I completely agree. I think the if the price quotient comes down with navigation or robotic, I think this will be like a SIAM. 30 years, 40 years back, we had no SIAMs in a lot of places. They used to do X-ray, but now SIAM became very, very easy and user friendly because cost is reduced. Because the cost constraint, people are not using it. But tomorrow, if the companies come with Indian companies come with this navigation which is less than a CR, then it will make a big difference. Because in my practice, I'm using, if our unit is doing 2000 plus surgeries per year, 1000 surgeries are navigation based. Maximum amount of cases do not have a pedicle problem or a problem because of the screws. So even in standard surgeries, I am personally using navigation completely. I am reducing my charges, but I think patients should get the benefit. Though I don't want to take a chance. Even if my fellow is doing the case or my colleague is doing, I think that is what we have realized, and we should give the best outcome to the patient. At least risk of pedicle screw or instrumentation is gone. Whatever there is a compression, severe compression, you decompress, patient develops a weakness, that's a different situation altogether. But at least mechanical problems which we can reduce, that's a great tool. And all India, all institutions start using navigation, prices will come down, and that will be a great day for Indian spine, where 95% of the patients will be safe in terms of general surgical risks.
We want a quick answer before I invite Lucas, who's basically working in Sweden, and we just heard that there are a huge number of robots in that small country already established. We'll hear from him because he's come on from open techniques to navigation to robots. We want a quick answer before we go on to Lucas.
I think, sir, when we talk about statistics, but then healthcare, even one patient, if you can save any complications, that should be a significant contribution. So anything that can lead to even saving one patient complication, I think we should do it.
Lucas.
Hello, everyone. Well, my answer might be a bit controversial. I don't see robotics as a machine for screw placement, actually. I see it beyond the screw placement. I see robot as a future machine for pre-planning and the pre-surgical intellectual effort, especially when it comes to the AI planning and support, which will be part of my talk. So I understand that both sides of the aisle talking about the reducing the risk of complications. Obviously, an expert in putting screw pedicles with the navigation will be still the expert, and a novice with no skills in putting screws in the pedicle screws with the robot will still be a novice and will still make mistakes. So I don't see it as a something which will change a lot of value when it comes to robotics, but I think the intrinsic value in the robotics will be beyond this when we start talking about modeling, the prediction model, the risk stratification, and pre-op planning, custom-made surgeries beforehand, before they even happened. That I think will be the future of the robotics, and that will be a game changer. In that setting, the robot will take over the navigation, but I think the navigation is still beyond, because there will be a place for navigation and robotics in the future. That's what I believe.
Thanks, Lucas. You tore the words out of my mouth. I would invite Dr. Chabra to formally introduce Lucas before he starts on with his talk.
Yeah, good evening. It's my distinct pleasure and honor to introduce our distinguished friend, Dr. Lucas Bobinski, who is an associate professor, Department of Orthopedics, Umeå University in Sweden. He's recognized for his expertise in advanced spinal disorders and minimally invasive techniques. He's actively involved in clinical practice, research, and academic training in spine care. He's also involved in international educational activities in spine surgery. For example, he's a Eurospine faculty and has co-authored multiple peer-reviewed studies on minimally invasive spinal procedures and related orthopedic research. Time is limited, so we will have a brief introduction, and he'll be talking now on ABLE in spine robotics, how learning algorithms improve accuracy and reduce error. Over to you, Dr. Bavinsky.
Thank you so much for that kind words, and thank you so much for inviting me. I'm very excited to be with you. So without further ado, I will just share my screen. I will hope that I will be on time. So ABLE in spine robotics. So we could translate ABLE as artificial intelligence and behavior and learning enhancement, or the ABLE as a platform from which interconnects navigation and robotics. So there are plenty of so those are my disclosures, and there are plenty of algorithms, and basically what algorithm stands for, it's a finite ordered sets of instruction used to solve problems or perform computations, and they can be applied both for hardware and software-based system. In medicine, especially in robotics, there are several of those which can be included. Greedy algorithm for planning of screw trajectories, dynamic programming for planning of surgery performance, backtracking for avoiding the collisions between the instruments and anatomical structures. We already implemented some of the algorithm in our practice. I would encourage everyone to read the checklist manifesto by Tool. He is an American Indian heritage surgeon who put out the word about implementing the checklist, which is step-by-step fashion, which is the core of the algorithm. However, if we look at the 2013 survey, almost 50% of surgeons admitted that they performed surgery on a wrong level. More than 10% performed surgery on the wrong side, and only 40% believe that checkout and timeout protocols and site markings give value to the surgery. So this intrinsically is connected to our human psychology, because learning requires openness to change and willingness to change on their own assumptions, but we naturally tend to defend our habits, beliefs, routine, even when we are confronted with the evidence. So that's problematic. Well, let me a bit elaborate on this. So according to the David Kolb Learning Circle, it is a continuous process with the interconnected components. And right now, the robotics and AI-driven systems can already deliver an accurate and reliable surgical execution, but they cannot yet independently create surgical strategies and continues interpret the interoperative data, which makes that the human touch and human collaboration with the robot is so intrinsic and so important. So what does it mean for us? Well, if we go back to the somehow controversial tweet of Elon Musk, who triggers some of the neurosurgeons, I personally believe that the robots won't supersize humans, but there is a catch in my statement, because I think that ultimately the surgeons who are using the robots for processing the data and pre-planning their surgery will probably supersede the doctors who are not. And I understand that it's somehow controversial, but let me attempt at least to make a case of it. So we all know cases like this, and cases like this make always for a very bad day. So the current state of the AI-driven medicine, we can divide into two domains. So First one is to using the robotics to implement in the surgery and the AI assistant approaches and optimization, but also equally important, the integration of the data processing, intelligence, risk stratification, modeling, predictions, etc. So we all have this, and this is well established and designed. We can stratify the risk. We can calculate the parameters. We can even categorize the attempted interventions. But this has no really any value when we don't have surgical execution which match their level of precision, predictability, and reproducibility. So how good are we performing? Well, in this study, the researchers found that if we attempt to correct all three parameters, that was achieved only in less than 40%. Another study showed that almost 30% of the cases were either not corrected or even malaligned after the surgery. Even simple tasks when you ask experienced spine surgeon to bend the rod toward the acquired level of degree of the correction, they tend to overshoot their correction by 20 degrees. While if they use the template, that difference disappears completely. So when I was in UK, I saw this way of establishing the planning. But what I've noticed is that this really well designed and well thought through, I would say, planning disappeared during the surgery because a lot of screws were not put because they had the surgeon struggled to put them in. The diameter length of the screws changed, and also the parameters of the correction changed during the surgery. So how can we approach this? Well, even from my own background, if I look at the outcome of the patients after regular surgery, that's the degenerative lumbar instrumented surgery, almost 65% of the patients, the reoperations were due to the implants. So there's plenty of room for improvement. And it's not only how the screws will sit in the spine, but also how they align with each other and how the correction of that will be performed. And the robot will always overperform human by this accuracy of the execution of the planning. So this is no doubt about it. So let me give you an example of how I see the robotics in the future. So I started using UNIT, which is the adaptive system in which the image analysis is then made for case simulation, followed by personalized produced implants like rods, and then the data collection and ultimately the machine learning and predictive modeling based on previous surgeries. So I will give you an example of the female patients of mine. The three problems I had with her is that she had severe back pain, she had restricted mobility, she already had been operated previously for bilateral hips replacement, but also had a Charcot-Marie-Tooth disease. So I really wanted to match her requirements for correction with what I can do. So that's why I decided that she would be ultimate patients for the unit. This is the planning. And on that planning, the rod was produced, which is obviously the template which I'm using to see whether or not I have achieved my correction in the proper way. But during the pre-planning, that's what beauty is, where I can play along and find the best way to put the implants in the right position so they not only sit in the pedicles, but also are well aligned with each other. And I can back and forth change them in both the coronal and the sagittal. Ultimately also using the possibility for simulate the correction to see whether or not I have achieved the placement of my implants in the right position. So when it comes to the surgery, I can just drop the rods in a place without any hassle. And this is the way it's done. So without on the left, this is the image without simulation, and then with the simulation showing that the purple screws are not matching the rods, while the yellowish and bluish implants are perfectly matching the rods. And I can play with this back and forth how much I want. This software allows me also to track all the changes in the osteotomies, the length of the screws, length of the rod, the position of the rod in between, the angulation of the screws, the distance between the screws, and that's builds enormous of data, which is accessible during the surgery and can be still changed whatever it needed to adapt to have the surgery as perfectly custom made for a patient's need. Furthermore, we can start doing the pre-plant drilling. Obviously, this is a bit of a hassle, but it's a first step to learn robot to perform, let's say, laminectomies and maybe in the future also osteotomies. So I started playing with this part of the software to be able to see whether or not the accuracy of drilling the facet is precise enough or not. Finally, the robotics allows us to use the able. As you can see, I can connect both the ORM robot, but also navigation, and use the robot as a navigator, not as a robot, as you can see on the left, and then as a robot on the right. So I'm trying to find a solution for the patient so that fits the needs of the patient so seamlessly. So I have no issues with putting the implants, and there is no risk for complications. Finally, you have the rod, which is pre-band, as you can see, that eliminates the soft spot and the hot spots from the rod and minimizes at least the risk of rod breakage. And finally, the beauty of this is that when you see that the rod is reduced without any issues, without any extra banding, without any hassle, that you know that your rod is your template of your correction, and that correction will ultimately resemble your initial planning. So if I can summarize my points here, is that plan of the surgery will advance the algorithm step-by-step fashion. It puts far more pressure on the surgeon to pre-plan and use the intellectual capacity and work than just the performance. But during the surgery, they also help us to execute our planning, and that preoperative visualization of anatomical structures can help us to adjust the osteotomies, the positioning, rod contouring, and alignment, which gives us much more safe space during the surgery and makes us much more, I would say, put us in much less stress during the surgery, and makes the surgery to flow much easier without any issues whatsoever. And that enhances the intraoperative execution consistency and reduce the risk of complication, obviously. And then we can go further with systems like this for patient-specific implants tailored to required correction, help with the support of the AI, and then finally systematically collect data of those cases to build up probably future algorithms for surgical performance. That was my last slide. Thank you for your attention.
Thanks, Lucas. That was extremely absorbing lecture, and really enjoyed the way you put across the futuristic adaptations which surgical skills and surgeons would undertake to incorporate robot in their day-to-day practice. You're open to questions now, and Dr. Chabra would be the starter, I'm sure, for asking him the first question.
Yeah, a very nice presentation, Dr. Lucas. We heard about the benefits, but we would also want to hear from you the limitations and the future of this technology.
Well, thank you for that question. It's a very important question, and yeah, I would say a bit of the points which were brought up before by my distinguished colleagues we're in the beginning of the journey. And the reason why I wanted to start with robotics, because I see the robot as a door to a future, the future which we don't know and we don't understand, and maybe we're a bit afraid of, but the future which we need to make that step, because no one questions the use of the seatbelts. No one questioned the use of, let's say, the airbags. No one questions the use of the iPhone. We need to remember that before iPhone, the Nokia was the #1 producer of the cell phones, and no one wanted to hear about strange device which you could tap on the screen and have your telephone, your camera, your calendar, your everything inside. And then the iPhone supersede the BlackBerry, the Nokia, all the communication system was just beat down to the pulp by iPhone. And this is something which I see in the robotics. I don't really understand how it's going to take us to the future, but I'm pretty sure and I'm convinced in my, let's say, in the conviction that the AI-driven technologies will just expand. They will enter the realm of surgery, and we'll have to adapt to them. Regardless if we want it or not, we either step on that train into the future, or we're gonna be left alone on the platform, and then there will not be coming back. So I would put this a bit philosophically.
Thanks, thanks, Lucas. Vidya has a question. Dr. Vidyadharan is the most prolific robotic spine surgeon in the southern part of India, and he has created many records in terms of, for instance, published extensively on robotics. Vidya.
Thanks, Dr. Basu. Sir, Dr. Lucas, it was very nice listening to you with the recent advances and your thoughts on ABLE. The only question, or rather concern, that I have is, how does your rigid rod, which is pre-contoured, does it have an effect, or rather, does it have a ambiguity in deciding based on the patient's bone quality? Because you have a rigid rod, you are trying to correct it, and your bone may not be holding it. And do you decide your osteotomies or bone cement augmentation things for the screws before putting these rods in place? Because you're pulling the bone to the rod rather than giving that what do you say, your flexibility of the correction on table.
Well, thank you so much for that question. It's a very important question. Yes. Well, I approach this in the same way that you would approach any scoliosis and deformity. I try to achieve as much flexibility to the spine, so it's more or less naturally flows and follows when I'm reducing the rod. What I see as an advantage in that system is that the rod is a template of the correction I want to achieve, rather than something which I'm going to force the spine to follow. So if I feel that the spine doesn't do it, I haven't achieved enough mobility, so the spine follows to the reduction, then I continue with the bone work. In that term, I try to create situation that when I reduce the rod, there is no rod bending or any other changing in the contouring. So I know that I have applied the forces equally through the construct. So this is pre-planned beforehand. Obviously, during the surgery, I need to work back and forth to see whether or not I have achieved this. But again, this is the matter of, let's say, future endeavors when we go back and forth and maybe start doing more and more advanced type of deformity corrections with that technique and see what are the limitations. But right now it's just a tool which helps me to have, let's say, a plan which I'm happy with, and then try to achieve that goal and execute my surgery according to that goal. Is that enough an answer to your questions?
Thank
Are
you,
you
Dr.
happy with this?
Yes, yes.
Thank you.
Rupinder, a question next.
Sir, this is the Bhavuk and Salesh debate. Bhavuk, you said the only main benefit is you tired, tremors, and all those things. But do you get tired putting 15, 20 screws a day? And to Salesh, the tactile sensation is important. Being an orthopedic and I don't use a robot, for me, sensation is important. The feel is good. But that is important in osteoporotic. And in osteoporotic spine, you already plan your things. Like if you are lumbar spine, you try to put a maximum diameter 6.5, or you put a cement augmented screws. And you don't take out a screw and put again a screw. So that doesn't change. The tactile sensation doesn't change. Your planning has to be done before.
I think Bhavuk may answer to Rupinder's question.
So, sir, so as I rightly said, the navigation tells you the pathway in osteoporotic spine also. But, in osteoporotic spine, it is also prone to reference frame, maybe, deviating. There may be some, because of the osteoporosis, that reference frame may not be giving you the actual direction of the navigation. So robot will tell you that this is wrong. This pathway is the pathway which you're trying to follow is wrong. So robot basically makes you, the aware of the error, and it stops you from making this error. And regarding the number of screws, I'm not talking about 15, 20 screws, but if you're putting these 90 or 80 screws in a day in setup, then it does matter.
Can I add to this?
Yeah, sure.
Bharat.
Yeah. Rupinder, I think we used to call Dr. Ajay the robot when we did not have the robot. He used to have the real classic 3D in his mind. But then he had we had the initial question dialogues, whether to integrate or not, or do this or that. At the end, there are pedicles which are real challenge. And after he has started using it, that has made the difference. That is one. Your confidence has improved. That is two. Time taken has reduced. That is three. And the fourth, most important, is the second spin. Because once you have done the spin and you take the spin at the end, that confirms that whatever you have done is the work and the art which is done best and the best possible way. So these are the issues which are solved by the navigation and the robot both. Over to you, sir. Thank you.
Thanks. Bharat had put a question in the chat box, so we will have that last question before we move on to the debate with the permission of the chairpersons. Bharat, put across your question.
My question was to Dr. Lucas. You have planned a surgery with the robot, everything is all going to go, and then you find that the robot, there is some technical error. How do you handle that?
Thank you so much for that question. Well, I'm very biased toward this because not only I have a robot in my institution, but I also have two arms. So it depends what the case is. Well, if the case requires a lot of correction in the patient who really needs the PILL perfect alignment, I would probably reschedule the case. But if it's a smaller case in which I can just go with the navigation, I will go with the navigation, but I will use the pre-planning from robot as my template. So this is the beauty of the Able, the platform, that you can incorporate the ORM navigation, the robotics, the navigating instruments together and find that sweet spot in which you can really perform despite the obvious obstacles coming in your way. So just to cite Professor van der Kleft, who is also a very distinguished surgeon and I would say also an early adopter of the robotics and the navigation, he usually say even the best surgeon can have bad days. The robots always, even the worst robot, it will perform on the same way. Either it perform or not, but if it performs, it performs every time in a simple way. So that would be probably the advantage of looking at the robot.
Thanks,
Dr.
Lucas. We'll have to move on, Dr. Chabra, and Dr. Rupinder will be moderating the rest of the session. And unfortunately, I have something coming up. I have to jump off to another meeting. Apologies for this, Dr. Chabra. It was an excellent opportunity for me to join. Thanks.
Thanks, Dr. Soumyajit, and you have spearheaded and launched so many special interest groups, and we need to thank you for getting this going. Of course, ASSI, we need to thank, and Rupinder as well. Dr. Lucas, before I start with the debate, I'll just want to inform you how Bharat would respond if the robo fails, right? Bharat is finding an excuse to get the second robo in his institution where there are 4 OAMs. So I'm sure Bharat will rope in the other robo, right? So fine, that was just a small joke. So we have this panel discussion from evidence to adoption. What should surgeons and systems do now? And our panelists will be Dr. Lucas, Dr. Bharat Dave, Dr. Vidyadhar. I think Guru is not there, is he? Guru has not joined, right? So, Bhavuk, are you there?
Sir, he is muted.
Yeah. So we will request Bhavuk to join in, or with Mirant can also pitch in where required, right? So now translating means this panel discussion gives us an opportunity, right? There has been a debate and there has been a strong debate with people vouching for one technology or the other. What is the practical decision making for robotics versus navigation in pedicle screw fixation and beyond? So how we translate this debate into practice is what we would be discussing, and we will start asking the question to Dr. Lucas Bobinski. How should an individual surgeon decide about which technology, robotics or navigation, to use?
Thank you. So, as I mentioned, I'm extremely biased because I use the both navigation and the robot. But I do think that we already seen that the both sides of the aisle presented with the solid arguments why you should consider one and the other. So I think I don't really see navigation as and a robot as enemies and more or less a 0-1 sum. I think those two technologies don't have to be mutually exclusive, and you can complement each other if you can afford it. Obviously, there is a economical issue here if you need to use one and you cannot afford the other. To me, as my distinguished colleagues mentioned, I would say extrapolate on that is that I would suggest that if you choose between robotics and navigation, and you need to evaluate your individual surgical profile, because if you work in an environment that you need to have that requires excessive intraoperative reevaluation, adaptation, and flexibility, especially when it comes to severe cervical trauma or emergency oncology infections, that probably navigation will be much easier for you, because then it can easily be adapted intraoperatively. However, if you are working in the high volume, severe deformity environment, which requires a lot of mind power behind it, a lot of planning. The team is very big, and you don't really afford making mistakes. Probably robotics will be much better for you, because then you can even you can expand on that environment and make that even more controlling in a setting like I said, deformity, and then you can expand beyond by putting a lot of effort to have a pre-planned surgeries and help with the help of the robot execute your planning. So that would be my approach to that.
Thanks, Dr. Lucas. Let's see at what the evidence has to suggest with regard to individual surgeon decision framework. What are we trying to optimize? That is, what is the goal of technology selection? Of course, accuracy of pedicle screw placement, but beyond pedicle screws also is what we are discussing today. Patient safety and complication reduction, radiation exposure, operative efficiency, and surgeon ergonomics and confidence. We know that both robotics and navigation improve accuracy versus freehand, and this supports using technology-assisted placement. But when you try to compare the two, as Dr. Lucas Bobinski said, Robotics is helpful in complex deformity, but also in multi-level surgeries and MIS surgeries. The learning curve may be a bit more than that of navigation, and setup and initial operative times may be a bit longer early on in the experience than navigation per se. And navigation, on the other hand, has shorter learning curve than robotic arm platforms, and can still depend on surgeon skill in adjusting trajectories intraoperatively, as Dr. Lucas talked about. Uh, Robotics may have less angular deviation, greater procedural consistency, especially for multi-level MIS cases. So MIS centers with high volume MIS cases also, it may be a preferred technology, but evidence is still emerging. Neither technology is unequivocally superior across all scenarios. So, if we were to look into it, you would prefer navigation if there is limited OR support, if you prefer manual fine tuning, and you would prefer robotics if there is multi-level fixation, deformity correction, or long constructs, as Dr. Lucas talked about, or you have a desire for highly reproducible pre-planned trajectories per se. So technology choice should be case specific, surgeon specific, and context specific, not dogmatic. So this is what the evidence suggests. So we come to the next question, and we will request our friend Bharat to address that. How should a hospital decide about which technology, robotics or navigation, to use? We just talked about surgeons. How should the hospital, and incidentally, Bharat is also a manager because he runs a spine hospital, and that's why I kept this question specifically for him. So what should be the institutional or hospital decision framework?
Yeah, I think thanks, Dr. Chavra, to put this question through. I think it has got few implications. One is usually we give choice to the patient, and usually we give the patient's pocket the weightage. That is most important because then the robot has got its drape to charge extra. That is one. Second thing, robotics needs certain screws as well. So this is where the patient pocket is considered as well. So the hospital management would consider the patient, and we do not want, we certainly want to give best to the patient, but that is where we select the navigation over robot. So that is one. Second thing, about the maintenance and about the workflow. These are the two most important points. If I have got a staff who is trained for the robotics, then I'm more than happy. But if I have got a staff who is not really worth, experience about the robotics, then I would certainly consider that as the negative side as well. And the most important thing is the breakdown, because that is something which I am all the time worried about. So if I have to really select a case which is complex case, and then that's where the robotics will certainly of great help. That's where the money is not considered at all. So something which is real complex case, real deform, scoliosis, where there is no pedicle, that is where we would consider robot as well. And the last and the most important thing is the surgeon who is operating. How much experience, how confident he is over the navigation.
Bharat, we are losing you. Maybe if you switch off the video and speak, we didn't hear the last part
Yes.
of it.
Yeah, so mainly the surgeon who is doing the surgery, that is what I would consider that as additional factor as well in decision making related to the robotics and navigation.
Thank you, Bharat, and let's look at what the evidence has to say. So when we look at hospital priorities, what hospitals do consider is clinical outcomes, cost and return of investment, OR throughput and turnover, as you talked about, staff training and retention, as you talked about, and patient safety and satisfaction. So we know that these are tech-assisted placement deals, and these generally translate to potential reductions in revision rates and improved quality metrics. There's a capital and recurrent costs, but the value drivers are shorter length of stay and fewer complications, so lower downstream costs. Improved OR efficiency in select cases may improve throughput, especially in robotic systems. So there would be implementation considerations like institutional readiness, the OR staff training and support structure, IT integration, credentialing and proctoring programs, and there may be a workflow impact like scheduling implications of longer setup times initially, need for dedicated technicians. So navigation in the hospital decision tree would be favored when there are budget constraints, broad utility across multiple specialties, surgeon proficiency and case mix align. Whereas robotics could be favored when there is high volume of complex MIS spinal cases, strategy prioritizes innovation and differentiation, and there's a willingness to invest in training and long-term outcomes. So institutional technology adoption should be volume-driven, outcome-focused, and aligned with long-term strategic goals, not based on novelty alone. That's what the evidence suggests. So we'll come to Dr. Vidyadhar. What is the Indian context of cost sensitivity?
Thank you, Chabra sir. In India, the cost sensitivity is not a side issue, it is the core reality. Most spine care is still out of the pocket, and even insured patients have package limits. So adoption question cannot be, is robotics better? It has to be, is it better enough, often enough to justify the cost? That means we must define the value in Indian terms, reduce complications and revisions, reduce OR time variability, faster mobilization and discharge, higher throughout without compromising quality, and most importantly, reproducibility across surgeons and centers. In India, technology adoption must be selective, high volume, and outcomes driven, not prestige driven. I think if at all we can come up with some Indian model of robot which is cost effective, I think it will be the way forward for Indian scenario. Thank you.
Thanks, Vidya. Very well answered, and we will quickly run through what the literature has to say. In India, there is high out-of-pocket healthcare spending. India's private healthcare model still has up to 60 to 70% out-of-pocket component. There are capital cost barriers, as we are aware about, and cost sensitivity often influences consent and procedure selection, and there is limited insurance coverage for advanced tech, and this increases the burden on patients. So let's come to the next question. I will request Dr. Bhavuk to answer this. Bhavuk, we are requesting you to be on the panel. And what is the Indian context of case volumes?
Sir, as rightly said, the case volumes, it makes a difference, So if robotics carries a value, if you have a high volume surgeon, also, the type of case volumes also determine. So like in my practice, in my experience, if your case volumes have more volume of the adult deformity, so probably robotics is of much value. But if your case volumes are more of the pediatric types, then probably the navigation is better than the robotics. So the case volume does make a difference, and high volume centers, they should consider for robot.
Thanks, Bhavuk. Let's see what the literature has to say. Regional variation in case mix and volumes is there in India. So there is high spine surgery burden in tertiary urban centers, and low volumes in tier 2 or 3 centers may limit ROI from high-end tech, as we have already discussed about, right? So if we see most of the case volumes are in tier 1 cities, and there's where this technology may come to play. So a hospital should consider evaluating spine case mix across locations, prioritizing tech deployment in high volume tertiary centers, and cross specialty use, right, to increase utilization. And surgeons should consider, are there enough eligible cases to justify personal credentialing, and could cross cover practice help maintain proficiency? So we come to the next question. I will request Bharat to answer it. What is the Indian context of resource variability?
This is the real challenge that we face. So Indian concept of resource variability varies from single surgeon to having a group of surgeons working together. And that is where, I think a single surgeon will be very difficult to adopt the technology. But if you have five, six, seven surgeons working together, then I think you can justify. If you have a big volume center, then that is again you can justify. Now coming to our way of handling, the Savia way of handling the resource variability. Whenever we look at any technology, we go for the CMC, 5 years of CMC. That is very important. So that resource I do not have to look at. But that is the most important thing which we, as a Stavia, kind of technology integration, that is where we win. Because then we are not worried about the ROI. How am I going to generate this in 1 year? So that is one. Second thing, the usables, meaning gluons, meaning all those things. So we also try to adopt thing in such a way so that the generation of the implant usage and the income, they get integrated as well. So that is where I do not need to worry about those things when I have to order or extra buying. And if I have to replace now, all our instruments are now 7 years old. So we really need the replacement as well. So that's where, I am ready for my volume that, I can replace them sooner, or I can replace them as and when required immediately. So resource variability is very important. When we had one OARM and when we decided to buy the second OARM, then the most important thing was the CT scan, the radiation, and everybody was worried about that. So that is where, we had waited for nearly 4 months. Everybody got convinced and everybody was ready to have that resourced into the system. So then we accepted that. So that was something which is very important, that the resources were utilized to its optimum. And the most important thing, the people who are working with the technology, the ergonomics of them, of their ergonomics is also taken care of. Like, all our surgeons at the moment, those who are working, they all have neck pain, they all have some tingling numbness going on. And starting from the younger one to the elder one, all have the same issue as well. So the resource variability certainly has got a role, probably not just in Indian context, but everywhere. That is something which is very important. So that is how the Stavia works for the resource variability. Over to you, sir.
Thanks, Bharat. Very well answered. Let's look into the literature. So, tertiary private hospitals versus government or charity hospitals, there's a large resource gap in infrastructure and staffing, as you are aware about. Trained navigation or robotics technicians may be limited, and not all centers have advanced intraoperative imaging. So, for resource variability, the actionable strategies for hospitals would be phased implementation, start in centers with basic infrastructure, shared resource models, regional centers of excellence, training programs, invest in staff and surgeon upskilling, and understand for surgeons, the actionable strategies would be understand facility limitations before case selection and advocate for structured OR case training. So, if we were to summarize the Indian context, when it comes to cost sensitivity, technology should be deployed where value, that is clinical plus economic, outweighs cost. For case volumes, high utilization is essential to justify investment and achieve outcomes. And for resource variability, adopt flexible, scalable implementation models aligned with facility capacity. So we come to the next question, and I will request Vidya to answer that. Will navigation and robotics merge? This has been partially answered, but I would want you to reinforce this.
Thank you, sir. Thank you for asking me to answer this. They have anyway already merged, and otherwise, if they do not merge, it is incomplete. Navigation without robotics is guidance without consistent execution, like what Dr. Shailesh has already told. Robotics without navigation is precision without intelligence, like what Bhavuk has already said. So in the future, they won't be separate products. There will be one platform, and the competition will move to AI planning, like Dr. Lucas has already told, workflow integration and reproducibility at scale. So the future is not a debate of navigation versus robotics. The future is navigation plus robotics plus AI as one integrated spine surgery platform. Thank you.
Very well answered, Vidya. Bhavuk, you have also touched upon this in your debate. Would you want to add to this?
Yeah, so sir, as rightly said by Vidya, they have already merged. So right now, the hybrid, the combination of navigation and robotics is coming up as a big way. And in our practice also, when the robotics is not working or something, then we resort to navigation also for our practice. So I think the navigation is core of robotics. So there is no question whether they will merge or not. They are already, the incremental innovation of the navigation.
Fine. So, but there are still centers which work with standalone navigation, but ultimately, as both of you pointed out very well, the future convergence in spine surgery would be navigation, robotics, and as both of you and Dr. Lucas also mentioned, artificial intelligence. Why should we discuss future convergence? Navigation and robotics increasingly share planning and imaging workflows. Modern platforms already integrate elements of both technologies. Artificial intelligence is emerging as the unifying layer, and future systems are expected to be hybrid, as you both talked about. Navigation and robotics are increasingly interdependent. As we can see here, the integrated surgical solutions would be the future of spine surgery. So, will navigation and robotics merge? Robotic systems already rely on navigation-based planning, as you have talked about. Hybrid navigation, robotic workflows are increasingly reported. Literature supports synergy rather than competition, and future platforms are likely to offer seamless integration. So, there is a synergy rather than competition between the two technologies, unless we are talking about navigation as a standalone technology. There are hybrid system. There is evidence that hybrid systems improve precision and workflow efficiency, shared imaging, registration, and trajectory planning. And there is early clinical data which supports safety and accuracy. So, we'll come to the next question to Dr. Lucas. Will ABLE and other advanced features which are to be introduced still, you talked about that, and will they shift the balance?
Thank you so much for the question. So let me begin with the short anecdote. During 19th century in London, there was Robert Liston, who was well-known as the fastest knife in the West End. He was so fast that he was able to amputate the limb within 28 seconds. That made him almost like a celebrity. People were coming, visiting him to witness this spectacles. Problem is that on one occasion he amputated the leg of the patient and 3 fingers of his assistant within it, and then he, with the one swift movement, cut the jacket of one of the spectator, who was convinced that he got stabbed. He fall down, he fainted, and then he died because of the heart failure. And that is the fastest surgery, which results in a 300% of mortality rate. So with this in the context, I think that the question is, should we keep going with the one-man show and way of pushing for human who enters the ER almost like a goddess coming into the OR and performing? I think we should going from this and start be more or less humbled by the results and the research showing that we have a lot to do and to correct for the human error. So we need to distance ourselves from the surgical experimentation, and we need to go toward more optimized planning, the workflow, the integrated, the teamwork, the separating the surgery in the small algorithm like separate stages, so we can optimize and fine tune all of the part of the surgery to achieve the best results. So in that long sentence, I would say yes, we whether we like it or not, we will have to go toward the more predictable and AI supported planning of the surgeries in the future, with the help of the help of the AI, machine learning, and we will be more intellectually involved in surgery and less physically involved in the surgery in the future. And I will just finish with the quote from Fessler: "Don't let your personal limitation becomes limitations of your patient," which is my golden rule. If I cannot perform surgery, I try to send the patient to a surgeon who is better than I am, and then more or less I think about using technology and support from AI to compensate for my lackings and my shortcomings. So thank you for your attention and
Thank,
word.
thank you, Dr. Lucas. Very well summarized. Dr. Rupinder, with your permission, we'll just take 5 more minutes and wrap up this quickly.
Sure, sir.
So AI enables automated planning and risk prediction. Machine learning adapts trajectories to bone quality. But real-time feedback allows intraoperative correction and transforms guidance into decision support systems. So we have a very promising future. And will AI shift the balance? AI augments both navigation and robotics. The future differentiation will be intelligence driven. Surgeon remains in the decision loop, and there will be a shift towards adaptive and predictive execution. So from hardware driven to intelligence driven systems are where we are moving forwards. So the future scenarios: partial convergence with shared data layers, fully integrated AI driven navigation robotic platforms, semi-autonomous execution under surgeon supervision. So hybrid AI orchestrated platforms are what we are moving towards, and those who are not into it may quickly move into it, because as Dr. Lucas said, surgeons who use robotics, navigation and AI will replace those who don't, most probably. So the take-home messages from my side, I will quickly ask all the panelists also to quickly give the carry-home messages that they have for today's not only panel discussion but also webinar. So navigation and robotics are converging toward hybrid systems anchored by integration, interoperability, and shared data workflows. AI-enabled features like real-time adaptation and sensing are not distant future. They are becoming the backbone of next-gen surgical guidance. The balance will shift not by replacing surgeons, but by augmenting their decision-making and execution with predictive intelligence. And as we talked about, with smart and intelligent surgeons who use technology, probably shadowing those who don't. So it's time for all of us to adapt to technology before it is too late, because that's the way the world is going to go. We'll quickly request Dr. Lucas to give, though he has talked about what he wanted to convey, but your quick take-home message.
Well, first of all, thank you for the last words. I completely concur with your take-home messages. There's very little I can add on to this. Only to extrapolate on this, we need to remember also that we're living in the fast-forward-driven world, when the efficiency and the quickly eldering population of the West world will catch up with us. We don't have time to spare, unfortunately, to train our younger generation in the way we were trained before, because no one will put effort to teach someone 4 years to put pedicle screws. We have to use the technology to advance the performance with our younger generations. And I see it in everyday surgeries, when my colleagues put percutaneous screws with the navigation better than I used to put open with just a fluoro. It's just the way it is, and we need to just adapt. I would conclude that we need to see, adapt, and overcome the obstacles, and then the future will be bright for us.
Thank you, Dr. Lucas. Vidya, do you have anything else to add to take-home message or your perspective?
I think my biggest take home message would be see to believe. I think if you see one, you'll believe one. Thank you.
Thanks, and you demonstrated and showed amply in the Roboticon, right? Bharat?
Yeah, I think I have two parts, two component of it. One is the teamwork, because you really need to build the teamwork and you really need to divide the speciality. And my second intake would be having the cervical spine being taken as a subspecialty in the spine itself. The navigation and the robotics and the technology integration certainly has saved my heartbeat whenever I am in an area where I really need to be, and that's where I am comfortable using the technology. So integration is must. Thank you.
Thank you. That's why you have an integrated operative suite as well. And so you touched upon a very important point. Teamwork is always important, but it becomes all the more important when you have technology roped in. And especially when it comes to robotic, it's not the surgeon alone, it's the team which has a core role to play. Bhavuk, you'll have the last word. If Bhavuk is not there, I think Mirant.
I completely agree with all the take-home messages, sir. Robotics is going to change the world. We see AI changing the world every day, and I think that's the way forward.
Thank you. I would want to thank all, not only panelists, but all faculty who have joined us not only for this webinar, but the last webinar as well, and would want to invite you all to the Enabling Technology Special Interest Group session during ASSICon next Friday, and or next to next Friday, and we are looking forward to that. And please stay in touch. There are more webinars to follow, and we will have at least 2 webinars in the next 6 months for the Enabling Technology Special Interest Group, and we have planned for various other activities, including a multicentric research that we are going to carry on. So with these words, and thanking all delegates and all people who have joined in for the webinar, I would hand over to Dr. Rupinder Chahal to give his final wrap up for the session message for all of us.
Thank you, sir. And it was a pleasant to have great people talk about technology. What I can say is we cannot escape technology. Choice we have is how responsibly we embrace it. And with that, I thank our international faculty, Dr. Lucas, for sparing time. And thank you, Dr. Chabra, sir, Dr. Bharat, Mirant, Vidyadhar, Bhavak, Guru, and Salesh. It was pleasant having you. And thanks all the delegates for sitting through this session. See you next time. Thank you all.
Thank you. Thank you.
Thank you.
Thank you. Good
Bye.
night.
Good
Have
night.
a
Good
great
night.
weekend.
Good night. Thank you.
Bye.
Bye.
Look
Thank
forward
you.
to having you, seeing you again, Dr. Lucas.
Thank you. Likewise. Thank you for having me. That was a great session. Great minds. As they say, the great minds think alike, but idiots seldom differ.
Great.
Thank you.
Thank you. Thank
Great.
you.
Thank you so much, and have a great day.